25 to 50%, may improve. 50 to 100%, unlikely to recover function. What is the timing on the bad sickly of and me? Dressler syndrome 4 to 6 weeks U, LR_U_ch_2 to 7 days. _JI ventricle pseudoaneurysm 3 to 7 days. T ventricular aneurysm months, requires remodeling and thinning. Myocardia _, idineus, 50% of the time, _____________J. _J. J. 392. Section 7. 7. Non-ischemic heart. Heart. Dilated cardiomyopathy, defined as dilatation with an end diastolic diameter greater than 55 mm, with a decreased F. Can be idiopathic, ischemic, or from a whole list of other random crap, alcohol, doxorubicin, cyclosporine, shigas, etc. The ischemic variety may show subendocardial enhancement. The idiopathic variety will show either no enhancement or linear midmyocardial enhancement. There is often an association with mitral regurgitation due to dilation of the mitral ring. Restrictive cardiomyopathy, basically anything that causes a decrease in diastolic function. Can be the result of myocardium replaced by fibrotic tissue, endocardial fibroblastosis, infiltration of the myocardium, amyloidosis, or damage by iron, hemochromatosis. The most common cause is actually amyloid. Restrictive equals myocardial process, constrictive equals pericardia. Amyloidosis, deposits in the myocardium, causes abnormal diastolic function with biatrial enlargement, concentric thickening of the left ventricle and reduced systolic function of usually both ventricles. Seen in 50% of cases of systemic amyloid. Has a terrible prognosis. You can sometimes see late GD enhancement over the entire subendocardial circumference. Amyloid classic scenario, a long T is needed, like 350 millisecunds, normal would be like 200. T will be so long that the blood pool may be darker than the myocardium. Buzzword: difficult to suppress myocardium. Eosinophilic cardiomyopathy, low filler, bilateral ventricular thrombus is the classic phrase buzzword. You will need a long T to show the thrombus. Constrictive pericarditis, historically this used to be TB or viral. Now the most common cause is iatrogenic secondary to Capgore radiation. On CT the pericardium is too thick, 0.4 cm, and if it's calcified that is diagnostic. Calcification is usually largest over the AV groove. Sigmoidization is seen on SSFP cine imaging. The ventricular septum moves toward the left ventricle in a wavy pattern during early diastolic bounce. This bounce will be most pronounced during inspiration, indicating ventricular interdependence. This vs that, constrictive vs restrictive cardiomyopathy /1y. Pericardium is usually thickened in constrictive diastolic septa. Bounce is seen in constrictive, sigmoidization of the septum. Myocarditis, inflammation of the heart, can come from lots of causes, often viral, i.e. Coxsackie virus. The late GD enhancement follows a non-vascular distribution preferring the lateral free wall. The pattern will be epicardial or mid-wall, not subendocardial. Myocarditis times mid-wall late GD enhancement. 393. Sarcoidosis. Cardiac involvement is seen in 5% of sarcoidosis cases, and is associated with an increased risk of death. Signal in both T2 and early GD, as well as late GD, will be increased. Late GD pattern may be middle and epicardial in a non-coronary distribution. Focal wall thickening from edema can mimic hypertrophic cardiomyopathy. It often involves the septum. The RV and papillaries are rarely affected. Takotsubo cardiomyopathy. A takotsubo is a Japanese octopus trap, which looks like a pot with a narrow mouth and large round base. The octopus will go into the pot, but then can't turn around and get out. A condition with chest pain and EKG changes seen in postmenopausal women after they either break up with their boyfriend, win the lottery, or some other stressful event has been described with the shape of the ventricle looking like a takotsubo. There is transient akinesia or dyskinesia of the left ventricular apex without coronary stenosis. Ballooning of the left ventricular apex is a buzzword. No delayed enhancement. Subendocardial, infarct transmural, infarct subendocardial circumferential, amyloidosis. Midwall, HDCM midwall, myocarditis, idiopathic dilated OM midwall, myocarditis, sarcoidosis. Epicardial, myocarditis, sarcoidosis. 394. Section S genetic. Arrhythmogenic right ventricular cardiomyopathy, ARVC, characterized by fibrofatty degeneration of the RV leading to arrhythmia and sudden death. Features include dilated RV with reduced function, fibrofatty replacement of the myocardium, and normal LV. People use this major/minor criteria system that includes a bunch of EKG changes that no radiologist could possibly understand. If they are stupid enough to ask, just say left bundle branch block. Watch out for the use of fat SAT to demonstrate the fat in the RV wall. ARVC. Section 7. Non-ischemic heart. Dilated cardiomyopathy, defined defined as dilatation with an end diastolic diameter greater than 55 mm, with a decreased F. Can be idiopathic, ischemic, or from a whole list of other random crap, alcohol, doxorubicin, cyclosporine, shigas, etc. The ischemic variety may show subendocardial enhancement. The idiopathic variety will show either no enhancement or linear mid-myocardial enhancement. There is often an association with mitral regurgitation due to dilation of the mitral ring. Restrictive cardiomyopathy, basically anything that causes a decrease in diastolic function. Can be the result of myocardium replaced by fibrotic tissue, endocardial fibroblastosis, infiltration of the myocardium, amyloidosis, or damage by iron, hemochromatosis. The most common cause is actually amyloid. Restrictive equals myocardial process constrictive equals pericardia. Amyloidosis, deposits in the myocardium causes abnormal diastolic function with biatrial enlargement, concentric thickening of the left ventricle and reduced systolic function of usually both ventricles. Seen in 50% of cases. Cases of systemic amyloid. Has a terrible prognosis. You can sometimes see late GD enhancement over the entire subendocardial circumference. Amyloid classic scenario, a long T is needed, like 350 millisecons, normal would be like 200. T will be so long that the blood pool may be darker than the myocardium. Buzzword difficult to suppress myocardium. Eosinophilic cardiomyopathy, low filler, bilateral ventricular thrombus is the classic phrase I buzzword. You will need a long T to show the thrombus. Constrictive pericarditis, historically this used to be TB or viral. Now the most common cause is iatrogenic secondary to CAP or radiation. On CT the pericardium is too thick, 0.4 cm, and if it's calcified that is diagnostic. Calcification. Calcification is usually JLY largest over the AV groove. Sigmoidization is seen on SSFP cine imaging. The ventricular septum moves toward the left ventricle in a wavy pattern during early diastolic bounce. This bounce will be most pronounced during inspiration, indicating ventricular interdependence. This VS that, constrictive VS restrictive cardiomyopathy /1Y. Pericardium is usually thickened in constrictive diastolic septa. Bounce is seen in constrictive, sigmoidization of the septum. Myocarditis, inflammation of the heart can come from lots of causes, often viral i.e. Coxsackie virus. The late GD enhancement follows a non-vascular distribution preferring the lateral free wall. The pattern will be epicardial or mid-wall, not subendocardial. Myocarditis times mid-wall late GD enhancement. 393. Sarcoidosis, cardiac involvement is seen in 5% of sarcoidosis cases, and is associated with an increased risk of death. Signal in both T2 and early GD, as well as late GD, will be increased. Late GD pattern may be middle and epicardial in a non-coronary distribution. Focal wall thickening from edema can mimic hypertrophic cardiomyopathy. It often involves the septum. The RV and papillaries are rarely affected. Takotsubo cardiomyopathy. A takotsubo is a Japanese octopus trap, which looks like a pot with a narrow mouth and large round base. The octopus will go into the pot, but then can't turn around and get out. A condition with chest pain and EKG changes seen in postmenopausal women after they either break up with their boyfriend, win the lottery, or some other stressful event has been described with the shape of the ventricle looking like a takotsubo. There is transient akinesia or dyskinesia of the left ventricular apex without coronary stenosis. Ballooning of the left ventricular apex is a buzzword. No delayed enhancement. Subendocardial, infarct transmural, infarct subendocardial circumferential, amyloidosis. Midwall, HDCM midwall, myocarditis, idiopathic dilated OM midwall, myocarditis, sarcoidosis. Epicardial, myocarditis, sarcoidosis. 394. Section S genetic. Arrhythmogenic right ventricular cardiomyopathy, ARVC characterized by fibrofatty degeneration of the RV leading to arrhythmia and sudden death. Features include dilated RV with reduced function, fibrofatty replacement of the myocardium, and normal LV. People use this major/minor criteria system that includes a bunch of EKG changes that no radiologist could possibly understand. If they are stupid enough to ask, just say left bundle branch block. Watch out for the use of fat sat to demonstrate the fat in the RV wall. ARVC, dilated RV, with fat in the wall. Hypertrophic cardiomyopathy, abnormal hypertrophy, from disarray of myofibrils, of the myocardium that compromises diastole. There are multiple types, but the one they are going to show is asymmetric hypertrophy of the intraventricular septum. The condition is a cause of sudden death. There is a subgroup which is associated with valve obstruction, hypertrophic obstructive cardiomyopathy. Venturi forces may pull the anterior leaflet of the mitral valve into the valve, some systolic anterior motion of the mitral valve. Patchy midwall delayed enhancement of the hypertrophic muscle may be seen, as is an independent risk factor for sudden death. Non-compaction, left ventricular non-compaction is an uncommon congenital cardiomyopathy that is the result of loosely packed myocardium. The left ventricle has a spongy appearance with increased trabeculations and deep intertrabecular recesses. As you might expect, these guys get heart failure at a young age. Diagnosis is based on a ratio of non-compacted end diastolic myocardium to compacted end diastolic myocardium of more than 2.3:1. Non-compaction, spongy LV, with no myocardial thickening. Muscular dystrophy Becker, mild 1, and Duchenne, severe 1, are X-linked neuromuscular conditions. They have biventricular replacement of myocardium with connective tissue and fat, delayed GD enhancement in the midwall. They often have dilated cardiomyopathy. Just think kid with dilated heart and midwall enhancement. 395. Section 9. Tumors. Mets, 30 times more common than a primary malignancy. The pericardium is the most common site affected, by far. The most common manifestation is a pericardia. Effusion, second most common is a pericardia, lymph node. Melanoma may involve the myocardium. Trivia, most common met to the heart is lung cancer, pericardium and epicardium. Angiosarcoma, most common primary malignant tumor of the heart in adults. They like the RA and tend to involve the pericardium. They often cause right-sided failure and forward/or tamponade. They are bulky and heterogeneous. Buzzword is sunray appearance, which describes enhancement appearance of the diffuse subtype as it grows along the perivascular spaces associated with the epicardial vessels. Left atrial myxoma, most common primary cardiac tumor in adults, rare in children. They are associated with MEN syndromes, and Blue-Nevi-Carney complex. They are most often attached to the interatrial septum. They may be calcified. They may prolapse through the mitral valve. They will enhance with GD, important discriminator from a thrombus. Tumor vs thrombus. Cardiac MI is the way to tell. Tumor will enhance, thrombus will not enhance. Rhabdomyoma, most common fetal cardiac tumor. It is a hamartoma. They prefer the left ventricle. Associated with tuberous sclerosis. Most tumors will regress spontaneously, those not associated with TS are actually less likely to regress. Fibroma, second most common cardiac tumor in childhood. They like the foreseptum, and are dark on TL/T2. They enhance very brightly on perfusion and late GD. Fibroblastoma, most common neoplasm to involve the cardiac valves, 80% aortic or mitral. They are highly mobile on SSFP cine. Systemic embolia are common, especially if they are on the left side. 396. Sec 110N10 pericardiae. The pericardium is composed of two layers, visceral and parietal, with about 50 cc of fluid normally between the layers. Pericardial effusion, basically more than 50 cc between the pericardia. Layers. This can be from lots and lots of causes. Renal failure, UMIA, is probably the most common. For the purpose of multiple choice tests you should think about lupus, and Dressler syndrome, inflammatory effusion post-ME. On CXR they could show this three ways. 1. Normal heart on comparison, now really big heart. 2. Giant water bottle heart. 3. Lateral CXR with two loose end lines, epicardial and pericardia, fat, and a central opaque line, pericardia, fluid, pericardia. Effusion, Oreo cookie sign. The so-called Oreo cookie sign. Cardiac tamponade. Pericardial effusion can cause elevated pressure in the pericardium and result in compromised filling of the cardiac chambers, atria first, then ventricles. Ventricles. This can occur with as little as LOC of fluid, as the rate of accumulation is the key factor. Chronic slow filling gives the pericardium a chance to stretch. The question is likely related to short-axis imaging during deep inspiration showing flattening or inversion of the intraventricular septum toward the LV, a consequence of augmented RV filing. Another indirect sign that can be shown on CT is reflux of contrast into the IVC and azygos system. Pericardial cysts, totally benign incidental finding. Usually seen on the right cardiophrenic sulcus. They do not communicate with the pericardium. Rarely they can get infected or hemorrhage. They will show you an ROI measuring water density along the right cardiophrenic sulcus, and this will be the answer. Congenital eye-acquired absence, even though you can have total absence of the pericardium, the most common situation is partial absence of the pericardium over the left atrium and adjacent pulmonary artery. When the left pericardium is absent, the heart shifts towards the left. They could show you a CT or MI with the heart contacting the left chest wall, and want you to infer partial absence. Another piece of trivia is that cardiac herniation and volvulus can occur in patients who undergo extrapleural pneumonnectomy. Herniation can only occur if the lung has also been removed. Trivia, the left atrial appendage is the most at risk to become strangulated. 397. Section 11. Surgeries. Palliative surgery for the hyperplastic left heart. Surgery for hyperplasts is not curative, and is instead designed to extend the life, prolong the suffering, of the child. It is done in a three-stage process, to protect the lungs and avoid right heart overload. 1. Norwood or Sarno within days of birth. 2. Glenn, at 3-6 months. 3. Fontan at 1 to 5 years. Norwood, the goal of the surgery is to create an unobstructed outflow tract from the systemic ventricle. So the tiny native aorta is anastomosed to the pulmonary trunk, and the arch is augmented with a graft, or by other methods. The ASD is enlarged to create non-restrictive atrial flow. A Blalock Blalock-Torsig shunt, see below, is used between the right subclavian and right PA. PA. The ductus is removed as well to prevent overshunting to the lungs. Apparently, when this goes bad, it's usually from issues related to damage of the coronary arteries or overshunting of blood to the lungs, causing pulmonary edema. As a point of trivia, sometimes the thymus is partially removed to get access. Left-sided hyperplastic heart. Norwood procedure. ASD is enlarged. Enlarged. Creation of unobstructed outflow, maintain pulmonary blood flow, creation of neo-aorta with either A, BT shunt or B, Sarno shunt, enlarge ASD for non-restrictive flow. 398. Sarno, same as the Norwood, but in augment. Left-sided hyperplastic heart. Sarno, same as the Norwood, but instead of using a Blalock-Torsig shunt, a conduit is made connecting the right ventricle to the pulmonary artery. The disadvantage of the BT shunt undergoes a steal phenomenon, diverted to low-pressure pulmonary system. Classic Glenn, shunt between the SVC and right pulmonary artery, end to end, with the additional step of sewing the proximal end of the right PA closed with the goal of reducing right ventricular work, by diverting all venous return straight to the lung, right lung. Bidirectional Glenn, shunt between the SVC and the right pulmonary artery, end to side. The RPA is left open, letting blood flow to both lungs. This procedure can be used to address right-sided heart problems in general, and is also step 2 in the palliative hyperplastic series. If it's being used as step 2, the previously placed Blalock-Torsig shunt or Sarno shunt will come down, as the Glenn will be doing its job of putting blood in the lungs. Glenn. Fontan operation, used for hyperplastic hearts. The old school Fontan consisted of a classic Glenn, SVC to RPA, closure of the ASD, and then placing a shunt between the right atrium to the left PA. The idea is to let blood return from systemic circulation to the lungs by passive flow, no pump, and turn the right ventricle, the only one the kit has, into a functional left ventricle. There are numerous complications, including right atriomegaly with resulting arrhythmias, and plastic bronchitis. They cough up casts of the bronchus that look like plastic. Other surgeries. Classic Blalock-Torsig shunt, originally developed for use with TOF. TOF. Shunt is created between the subclavian artery and the pulmonary artery. It is constructed on the opposite side of the arch. It's apparently technically difficult and often distorts the anatomy of the pulmonary artery. High yield point. Glen equals vein to artery, SVC low pulmonary artery. Blalock-Torsig equals artery low artery, subdavian artery low pulmonary L1V. Modified Blalock-Torsig shunt. This is a Gore-Tex shunt between the subclavian artery and pulmonary artery. Artery, and is performed on the same side as the arch. artery, and is performed on the same side as the arch. Arch. It's easier to do than the original. U/JV. R. BT. Artery, and is performed on the same side as the arch. Arch. It's easy. BT shunt. 399. Pulmonary artery banding, done to reduce pulmonary artery pressure. Goal is L/3 of systemic pressure. Most common indication is CHF in infancy with anticipated delayed repair. The single ventricle is the most common lesion requiring banding. Atrial switch, mustard and Senning procedures are used to correct transposition of the great arteries by creating a baffle within the atria in order to switch back the blood flow at the level of inflow. The result is the right ventricle becomes the systemic ventricle, and the left ventricle pumps to the lungs. This is usually done in the first year of life. Senning, baffle is created from the right atrial wall and atrial septa. Tissue without use of extrinsic material. Mustard, involves the resection of the atrial septum and creation of a baffle using pericardium, or synthetic material. Rasterly operation, this is the most commonly used operation. operation for transposition, pulmonary outflow obstruction, and VSD. The procedure involves the placement of a baffle within the right ventricle diverting flow from the VSD to the aorta, essentially using the VSD as part of the LVO. The pulmonary valve is oversewn and the conduit is inserted between the RV and the PA. The primary advantage of this procedure is the left ventricle becomes the systemic ventricle. The primary limitation of this procedure is that the child will be committed to multiple additional surgeries because the conduit wears out and must be replaced. Replaced. Jayton procedure. This is another arterial switch method that involves transection of the aorta and pulmonary arteries about the valve sinuses, including the removal of the coronaries. The great arteries are switched and the coronaries are sewn into the new aorta, formerly the PA. Apparently this is very technically difficult, but the advantage is there is no conduit to go bad, and the lie is the systemic ventricle. Ross procedure. Performed for diseased aortic valves in children. Replaces the aortic valve with the patient's pulmonary valve and replaces the pulmonary valve with a cryopreserved pulmonary valve homographed. Follow-up studies have shown interval growth of the aortic valve graft in children and infants. Bent-Hall procedure, operation involving composite graft replacement of the aortic valve, aortic root. Root and ascending aorta, with reimplantation of the coronary arteries into the graft. This operation is used to treat combined aortic valve and ascending aorta disease, including lesions associated with Marfan syndrome. Heart transplant types. Orthotopic heart transplants, all of the heart is removed, except the circular part of the left atrium, the part with the pulmonary veins. The donor heart is trimmed to fit into the left atrium. Heterotopic heart transplants, the recipient heart remains in place, and the donor heart is added on top. This basically creates a double heart. The advantages of this are: 1. It gives the native heart a chance to recover, and 2. Gives you a backup if the donor is rejected. 400. Summary: most common surgery I. Key points. Glenn. J. Vein to artery I, SVC to pulmonary artery I. Chapter 9. Vascular Prometheus Lion Heart, MD. Highest yield tip. Vascular pathology lends itself easily to both anatomy questions and management questions. Acute aortic syndromes, vasculitis, carotid pathology can all potentially have a related management question. Although a lot of this will be covered in the IR chapter, I would at least start thinking about how this could be asked as you review the topics. 403. Section 1 Anatomy. Aorta. The thoracic aorta is divided anatomically into 4 regions: the root, the ascending aorta, the transverse aorta, arch, and the descending aorta. The root is defined as the portion of the aorta extending from the aortic valve annulus to the senotubular junction. The diameter of the thoracic aorta is largest at the aortic root and gradually decreases. Average size is 3.6 cm at the root, 2.4 cm in the distal descending. Sinuses of Valsalva. There are 3 outpouchings, right, left, posterior, above the annulus that terminate at the ST junction. The right and left coronaries come off the right and left sinuses. The posterior cusp is sometimes called the non-coronary cusp. Isthmus, the segment of the aorta between the origin of the left subclavian and the ligamentum arteriosum. Ductus bump. Just distal to the isthmus is a contour bulge along the lesser curvature, which is a normal structure, not a pseudoaneurysm. Ductus bump. Aortic arch variants. There are 4 common variations: normal, 75%, bovine arch, 15%, common origin off brachiocephalic artery and left common carotid artery, left common carotid coming off the brachiocephalic proper, 10%, and in 5% of people the left vertebral artery originates separately from the arch. Branching with regards to right arch, left arch and double arch was discussed in more detail in the cardiac chapter. Normal bovine left CC off separate origins brachiocephalic. 404. Adamkiewicz. The thoracic aorta puts off multiple important feeders including the great anterior medullary artery, artery of Adamkiewicz, which serves as a dominant feeder of the spinal cord. This thing usually comes off on the left side, 70 forward/0, between T8LL, 90%. Mesenteric branches. The anatomy of the SMA and IMA is high yield, and can be shown on AMIP coronal CT, or angiogram. I think that knowing the inferior pancreaticoduodenal comes off the SMA first, and that the left colic, from IMA, to the middle colic, from SMA, make up the arc of Riolan are probably the highest yield facts. SMA. Inferior. Pancreaticoduodenal IMA. Middle colic. Right colic. Leo colic. Appendicular. Appendicular. Celiac branches. The classic branches of the celiac axis are the common hepatic, left gastric, and the splenic arteries. The common hepatic artery becomes the proper hepatic artery after the GDA. This traditional anatomy is actually only seen in 55% of people. Arc of Riolan. Left 4 times CI times 0 IC. Dash 1 MA, RG in underscore ALA underscore ATA J. ATA J. Times sigmoid. Celiac anatomy. Remember, this can be shown with an angiogram, CTA, or MRA. Variant hepatic artery anatomy. The right Right hepatic artery and left hepatic arteries may be replaced, originate from a vessel other than the proper hepatic, or duplicated, which anatomist called accessory. This distinction of replaced vs accessory would make a great multiple choice question. Trivia to know. Replaced equals different origin, usually of the left gastric or SMA. SMA. Accessory equals duplication of the vessel, with the spare coming off the left gastric or SMA. If you see a vessel in the fissure of the ligamentum venosum, where there is not normally a vessel, it's probably an accessory or replaced left hepatic artery arising from the left gastric artery. The proper right hepatic artery is anterior to the right portal vein, whereas the replaced right hepatic artery is posterior to the main portal vein. This positioning of the replaced right increases the risk of injury in pancreatic surgeries. Vessel in the ligamentum venous, probably replaced left hepatic. 406. Iliac anatomy. The branches of the internal iliac are high yield, with the most likely question being which branches are from the posterior or anterior divisions. A useful mnemonic is /love sex, iliolumbar, lateral sacral, superior gluteal, for the posterior division. My trick for remembering that the mnemonic is for posterior and not anterior is to think of that super religious girl I knew in college. I like sex in the butt, I posterior. I don't think they will actually show a picture, it's way more likely to be a written question. Superior vesicular. Obturator. Inferior vesicular. Middle rectal internal pudenda. Pudenda. Lateral sacral. Superior gluteal. Anterior division, posterior division. L times. Times. Persistent sciatic artery, an anatomic variant, which is a continuation of the internal iliac. It passes posterior to the femur in the thigh and then will anastomose with the distal vasculature. Complications worth knowing include aneurysm formation and early atherosclerosis in the vessel. The classic vascular surgery board's question is external iliac is acutely occluded, but there is still a strong pulse in the foot. The answer is the patient has a persistent sciatic. Persistent sciatic artery. Mesenteric arterial collateral pathways. Celiac to SMA. The conventional collateral pathway is celiac, common hepatic, ODA, superior pancreatic duodenal, inferior pancreatic duodenal, SMA. Arc of Buller. This is a variant anatomy, seen in like 4% of people, that represents a collateral pathway from the celiac to the SMA. The arch is independent of the ODA and inferior pancreatic arteries. This rare collateral can have an even more rare aneurysm, which occurs in association with stenosis of the celiac axis. Hepatic. Inferior pancreatic duodenal. Celiac. SMA. Hepatic. Arc of Buller. Inferior pancreatic duodenal. Celiac. 408. SMA to IMA. The conventional collateral pathway is SMA, middle colic, left branch of the middle colic, arc of Riolan, as below, left colic, IMA. Arc of Rio /N, also referred to as the meandering mesenteric artery. Classically a connection between the middle colic of the SMA and the left colic of the IMA. Marginal artery of Drummond. This is another SMA to IMA connection. The anastomosis of the terminal branches of the iliocolic, right colic and middle colic arteries of the SMA, and of the left colic and sigmoid branches of the IMA, form a continuous arterial circle or arcade along the inner border of the colon. Marginal artery of Drummond. IMA to iliacs. The conventional collateral pathway is IMA-, superior rectal, inferior rectal, internal pudenda. - anterior branch of internal iliac. Left colic. 409. Winslow pathway. This is a collateral pathway that is seen in the setting of aortoiliac occlusion. Occlusive disease. The pathway apparently can be inadvertently cut during transverse abdominal surgery. The pathway runs from subclavian arteries, internal thoracic, mammary, arteries, superior epigastric arteries, inferior epigastric arteries, external iliac arteries. Corona mortis, classically described as a vascular connection between the obturator and external iliac. Some authors describe additional anastomotic pathways, but you should basically think of it as any vessel coursing over the superior pubic rim, regardless of the anastomotic connection. The crown of death is significant because it can a. Be injured in pelvic trauma or b. Be injured during surgery, and is notoriously difficult to ligate. Some authors report that it causes 6 to 8% of deaths in pelvic trauma. The last piece of Trivia is that it could hypothetically cause a type. Type 2 endoleak. 410. Upper extremity anatomy. The scalene muscles make a triangle in the neck. If you have ever had the pleasure of reading a brachial plexus MRI, finding this anatomy in a sagittal plane is the best place to start, in my opinion. The relationship to notice, because it's testable, is that the subclavian vein runs anterior to the triangle, and the subclavian artery runs in the trian 2 i.e., with the brachia, plexus. Trivia to remember, the subclavian artery runs posterior to the subclavian vein. Brachia. Plexus. Anterior scalene muscle. Phrenic nerve. Transverse process. Process C2 C3. Middle scalene muscle. Scalene muscle. Muscle. First rib. Subclavian artery. The subclavian artery has several major branches: the vertebral, the internal thoracic, the thoracocervical trunk, the costocervical trunk, and the dorsal scapula. As the subclavian artery progresses down the arm, anatomists decided to change its name a few times. This name changing makes for great multiple choice fodder. The highest yield thing you can know with regard to upper extremity vascular anatomy is when stuff becomes stuff. Axillary artery begins at the first rib brachia /art 1y, begins at the lower border of the teres major, ma / or not minor. Brachia /artery bifurcates to the ulnar and radial. 411. How to tell the ulnar from the radial artery. Brachia. Plexus. Plexus. Anterior scalene muscle. Phrenic nerve. Transverse process C2 C3. How to tell the ulnar from the radial artery on angiogram or CTA. Around the radial head the brachia artery splits into the radial and ulnar arteries. I have 3 tricks for telling the radial from the ulnar artery apart, in case it's not obvious. 1. The ulnar artery is usually bigger. 2. The ulnar artery usually gives off the common interoseous. 3. The ulnar artery supplies the superficial planar arch, usually, and therefore the radial supplies the deep arch, usually. Normal variants. Anterior interoseous branch, median artery, persists and supplies the deep palmar arch of the hand. High origin of the radial artery comes off either the axillary or high brachia. Artery, remember it normally comes off at the level of the radial head. High origin of the radial artery. 412. Lower extremity anatomy. Every medical student knows the aorta bifurcates into the right and left common iliac arteries, which subsequently bifurcate into the external and internal iliac arteries. The nomenclature pearl for the external iliac is that it becomes the common femoral once it gives off the inferior epigastric, at the inguinal ligament. Inferior epigastric / aorta common iliac external iliac common femoral. Once the inferior epigastric comes off, level of the inguinal ligament, you are dealing with the common femoral artery, CFA. The CFA divides into the deep femoral, profunda, and superficial femoral. The deep femoral courses lateral and posterior. The superficial femoral passes anterior and medial into the phlegm muscle compartment, adductor I Hunter's canal. At the point the vessel emerges from the canal, it is then the popliteal artery. At the level of the distal border of the popliteus muscle, the popliteal artery divides into the anterior tibialis, the first branch, and the tibial peritoneal trunk. The anterior tibialis courses anterior and lateral, then it transverses the interosseous membrane, running down the front of the anterior tibia and terminating as the dorsalis pedis. The tibial peroneal trunk bifurcates into the posterior tibialis and fibula, peroneal, arteries. A common quiz is what is the most medial artery in the leg, with the answer being the posterior tibial, felt at the medial malleolus. Notice how lateral the at is. You can imagine it running across the interosseous membrane, just like it's supposed to. Anterior tibialis. Anterior tibialis. Peroneal. Posterior tibialis peroneal. 413. Venous collaterals. Gastric varices, as described in more detail in the GI chapter. Portal hypertension shunts blood away from the liver and into the systemic venous system. Spontaneous portal systemic collaterals develop to decompress the system. The thing to know is that most gastric varices are formed by the left gastric, coronary vein. That is the one they always show big and dilated on an angiogram. Isolated gastric varices are secondary to splenic vein thrombosis. Gastric varices, 80 to 85%, drain into the inferior phrenic and then into the left renal vein, forming a gastrorenal shunt. Vein. SMV. Left gastric short gastric. Gastroepiploic vein. If anyone asks. Left gastric, coronary, equals cardia posterior and short gastric equals fundus. Splenorenal shunt, another feature of portal hypertension. This is an abnormal collateral between the splenic vein and renal vein. This is actually a desirable shunt because it is not associated with GI bleeding. However, enlarged shunts are associated with hepatic encephalopathy, discussed in greater detail in the BRTO section of the IR chapter. A common way to show this is an enlarged left renal vein and dilatation of the inferior vena cava at the level of the left renal vein. 414. Caval variants. Left-sided SVC, the most common congenital venous anoma JY in the chest. In a few rare cases these can actually result in a right-to-left shunt. They are only seen in isolation in 10% of cases, the other 90% it's duplicated. The location and appearance is a total aunt mini. Trivia to know. Most common associated CHD is the ASD. Associated with an unroofed coronary sinus. Nearly always, 92% of the time, it drains into the coronary sinus. Left-sided SVC, when you see that son of a bitch right there, that thing can only be one of two things, a lymph node or a duplicated SVC. SVC. Duplicated SVC. This is usually seen in the scenario of a left-sided SVC, with a smaller right SVC also present. Duplicated IVC. There are two main points worth knowing about this. 1. That the appearance is an aunt mini, and 2. It's associated with renal stuff. Renal associations include horseshoe and crossed fused ectopic kidneys. Also these dudes often have circumaortic renal collars, see below. Duplicated IVC. IVCs are the bread, aorta is the cheese or peanut butter. Or bacon. 415. Circumaortic venous coljar, very common variant with an additional left renal vein that passes posterior to the aorta. It only matters in two situations, A. Renal transplant, B. IVC filter placement. The classic question is that the anterior limb is superior, and the posterior limb is inferior. As it goes continuation, this is also known as absence of the hepatic segment of the IVC. In this case, the hepatic veins drain directly into the right atrium. Often the IVC is duplicated in these patients, with the left RVC terminating in the left renal vein which then crosses over to join the right IVC. The first thing you should think when I say azygous continuation is polysplenia. Reversed IVC /aorta is more commonly associated with asplenia. Azygous continuation, no IVG in the liver, dilated azygos in the chest. 416. Section 2. Acute aortic syndromes. There are 3 acute aortic syndromes: aortic dissection, intramural hematoma, and penetrating ulcer. Aortic dissection. This is the most common cause of acute aortic syndrome, 70%, and is most commonly caused by hypertension, 70%. This can be described as either acute. Stanford account for 75% of dissections and involve the ascending aorta and arch proximal to the takeoff of the left subclavian. These guys need to be treated surgically. Stanford B occur distal to the takeoff of the left subclavian and are treated medically unless there are complications, organ ischemia etc. Causes: hypertension is the most frequent predisposing factor for aortic dissection. Other associations include Marfan's, Turner's, aortic valve defects, infection, and pregnancy. Cocaine has also been associated in otherwise normotensive patients. Findings: displacement of intimal calcifications on non-contrast. An intimal flap is seen in only 70% of cases. When you do see two lumens, these will spiral around each other. Thrombus is located in the false lumen, which will enhance later and is generally larger than the true lumen. True vs false lumen. True-false continuity with undissected portion of aorta cobweb sign, slender linear areas of low attenuation, smaller cross-sectional areas, with higher larger cross-section area, slower more velocity blood. Aortic dissection. This is the most common cause of acute aortic syndrome, 70%, and is most commonly caused by hypertension, 70%. 70%. This can be described as either acute. Stanford account for 75% of dissections and involve the ascending aorta and arch proximal to the takeoff of the left subclavian. These guys need to be treated surgically. Surgically. Stanford B occur distal to the takeoff of the left subclavian and are treated medically unless there are complications, organ ischemia etc. Causes: hypertension is the most frequent predisposing factor for aortic dissection. Other associations include Marfan's, Turner's, aortic valve defects, infection, and pregnancy. Cocaine has also been associated in otherwise normotensive patients. Findings: displacement of intimal calcifications on non-contrast. An intimal flap is seen in only 70% of cases. When you do see two lumens, these will spiral around each other. Thrombus is located in the false lumen, which will enhance later and is generally larger than the true lumen. True vs false lumen. True-false continuity. Continuity with undissected portion of aorta cobweb sign, slender linear areas of low attenuation, smaller cross-sectional areas, with high Ultimo-intimal intussusception, unusual type of dissection. It is produced by circumferential dissection of the intimal layer, which subsequently invaginates. This has been compared to a windsock. The intimal tear usually starts near the coronary orifices. Floating viscera sign. This is a classic angiographic sign. Sign of abdominal aortic dissection. It is shown as a pacification of abdominal aortic branch vessels during aortography, catheter placed in the aortic true lumen, with the branch vessels, celiac axis, superior mesenteric artery, and renal arteries, arising out of nowhere. They appear to be floating, with little or no antegrade pacification of the aortic true lumen. Intramural hematoma, classically seen in old hypertensives, same as dissection. Spontaneous hemorrhage caused by rupture of the vasovasorum in the media without an intimal tear. This can be really difficult to distinguish from a thrombosed dissection. It won't spiral the way dissection does. Can proceed to classic dissection. Trivia. It's still classified type A or type B mortality predictors. Ascending aorta, 5 cm, IMH, 2 cm, pericardia. Effusion. Maximum aortic diameter, SCM, is the strongest predictor to dissection. Unenhanced CT scan depicts crescent-shaped areas with high attenuation. Intimal calcifications may be displaced. MRI will show T2 bright blood in the acute phase, and TL and T2 bright blood when subacute. Crescent sign of IMH. 418. Penetrating ulcer. This is an ulceration of an atheromatous plaque that has eroded the inner elastic layer of the aortic wall. When it reaches the media, it produces a hematoma within the media. These things most often occur in old people with severe underlying atherosclerosis. They can lead to saccular aneurysm. They are often multiple and therefore difficult to treat. You still use the A and B Stanford classification based on location, with corresponding medical and surgical treatment. Apparently when these guys need surgery for type BS, symptoms etc., they do way worse than dissected BS because they actually need surgery and can't get an endograft. Trivia. It's still classified type A or type B mortality predictors. Ascending aorta, 5 cm, IMH, 2 cm, pericardia. Effusion. Maximum aortic diameter, SCM, is the strongest predictor to dissection. Causes. What is the highest yield testable trivia regarding Section 3. Aneurysm and MISC. Aneurysm vs pseudoaneurysm. The distinction between a true and false aneurysm lends itself well to multiple choice testing. A true aneurysm is an enlargement of the lumen of the vessel to 1.5 times its normal diameter. True equals 3 layers are intact. In a false, pseudo, aneurysm, all 3 layers are not intact, and it is essentially a contained rupture. The risk of actual rupture is obviously higher with false aneurysm. It can sometimes be difficult to tell, but as a general rule fusiform aneurysms are true, and saccular aneurysms might be false. Classic causes of pseudoaneurysm include trauma, cardiologists, groin stents, infection, mycotic, pancreatitis, and some vasculitids. On ultrasound they could show you the classic yin/yang sign, with to and fro flow on pulsed Doppler. The yin/yang sign can be seen in saccular true aneurysms, so you shouldn't call it on that alone, unless that's all they give you. To and fro flow within the aneurysm neck and clinical history is the best way to tell them apart. SVC syndrome occurs secondary to complete or near complete obstruction of flow in the SVC from external compression, lymphoma, lung cancer, or intravascular obstruction, central venous catheter, or pacemaker wire with thrombus. A less common but testable cause is fibrosing mediastinitis. Just think histoplasmosis. The dude is gonna have face, neck, and bilateral arm swelling. Traumatic pseudoaneurysm. Again, a pseudoaneurysm is basically a contained rupture. The most common place to see this, in a living patient, is the aortic isthmus, 90%. This is supposedly the result of tethering from the ligamentum arteriosum. The second and third most common sites are the ascending aorta and diaphragmatic hiatus, respectively. Ascending aortic injury is actually probably number one, it just kills them in the field so you don't see it. They could show you ACXR with a wide mediastinum, deviation of the ing tube to the right, depressed left main bronchus, or left apical cap and want you to suspect acute injury. Classic isthmus pseudoaneurysm. 420. Ascending aortic calcifications. There are only a few causes of ascending aortic calcifications, as atherosclerosis typically spares the ascending aorta. Take ISU and syphilis should come to mind. The real-life significance is the clamping of the aorta may be difficult during CABG. Aneurysm, defined as enlargement of the artery to 1.5 times its expected diameter, 4 cm of the ascending and transverse, 3.5 cm descending, 3.0 cm abdominal. Atherosclerosis is the most common overall cause. Medial degeneration is the most common cause in the ascending aorta. Patients with colulective tissue, Marfan's, Ehlers-Danlos, diseases tend to involve the aortic root. When I say cystic medial necrosis, you should think